Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I'm Dr. Mahidah Ramli. Today I'm going to talk about the anatomy of hepatobiliary system. Well, it's in previous cohort, the anatomy of hepatobiliary system is supposed to be quite later in the timetable, but this year it started early because the changing of the weekly team. So, well, you might not really familiar with the terms that I put in this lecture, but I will try my best to teach you. Okay. Well, this week theme is about the hepatobiliary system. So I'm going to talk to you. I'm going to teach you on the gross anatomy of hepatobiliary system. Right. Okay, what is the hepatobiliary system? Okay, if it is the hepatobiliary system, it is referring to the liver, the gallbladder, and the bile ducts. Okay. They work together to make and store the bile duct. And when the GI system is in need of the bile, they will be secreted through the bile duct and into the duodenum. Right. So this is just introduction. What is actually the hepatobiliary system? What organ are you going to learn in this hepatobiliary system lecture topic? It is the liver and the gallbladder and including the biliary tree. Okay, this is today's learning objectives. Okay, we can divide it into two big chunks. Okay, number one is the anatomy. Okay, number one is the anatomy of the liver. The second one is the biliary tract and also the gallbladder. Okay. Everything about the anatomy of the liver, which includes all the surface anatomy, the lobes, surfaces, and relation. These two things is actually two different things. Okay, this is the surfaces, the surface of the liver itself, and the surface anatomy is where you can assess the liver from the external. Okay, surface anatomy of the liver, and then we learn on the structures that we call the portal hepatis, the blood supply of the liver, how is it, and then the portal carboinostomasis. Why are they so clinically significant, so important, and the basis for portal lobules and lobes of the liver, and some upper anatomy which related to the liver. And second chunk is about the biliary tract. So it's going to be a very short part, but it's going to be biliary tracts. What are there in the biliary tract, and what is the relation of the biliary tract to the foramen of Windsor? What is foramen of Windsor? And then we're going to learn about the gallbladder, everything about the gallbladder, and the supply, and some anatomy of the biliary tract and gallbladder. Okay, let's go to the liver first. Okay, liver. This is the liver. I don't know. Okay, what's liver? This is the liver. Hepa in medical term equals hepatobiliary. This is a hepato mean liver. Hepatocyte mean cells of the liver. So liver is the largest gland in the body. The weight of the liver is approximately about 2% of adult body weight, which is approximately 1.5 kilo. And in infant, it's small, which is 5% of infant body weight. They are brown reddish in color, and they are mostly intraperitoneal except the bare area. Okay, what's the bare area? Okay, we're going to learn this later. Okay, so what's the bare area? Okay, this is the bare area. So the bare area of the liver is not covered by the peritoneum. What is peritoneum? Okay, peritoneum is actually the covering of the abdomen. So the abdomen or the visual organ in the abdomen is covered by the peritoneum. Okay, remember we have cavity, abdominal cavity, cardiac cavity, pleural cavity. Abdominal cavity is covered by the peritoneum. So liver is covered by the peritoneum except at its bare area. The bare area is surrounded by the right and the left coronary ligaments. Okay, the right and the left coronary ligaments. The extension are known as the right and the left triangular ligament respectively. Okay. Okay. What is the function of the liver? The mainly produce bile, have the excretion of the bile, and they store the bile into the gall. Excretion of bilirubin, cholesterol, hormones, and drugs. They also metabolize fats, protein, and carbohydrates. They activate enzyme. They store glycogen, vitamins, and minerals. They synthesis plasma proteins such as albumin, clothing factors, and also make some blood toxification and purification. Okay. Before going to the surface anatomy of the liver, so where is the liver located? I'm going to introduce to you how we divide the liver, the abdomen based on two kind of division. Okay, number one is abdominal quadrant. Okay, abdominal quadrant, where we divide the abdomen into 4 quadrants. Okay, 1, 2, 3, 4. How do we divide this 4 quadrant? It is simply by the putting an imaginary line that passes through the midline. Okay, it's a xiphisternum, and the the sternum passes through the xiphisternum and the transumbilical through the line that passes through the umbilicus. Okay, from this abdominal quadrant division, we have 4 abdominal quadrant: the right upper quadrant, the left upper quadrant, lower right lower quadrant, and left lower quadrant. While another way of dividing the abdomen into its division is by dividing the abdomen into the regions. Okay, there are 9 abdominal regions which formed by the 4 imaginary line that passes through 2 mid-clavicular plane, right and the left sides. So on. Okay, and then subcostal plane, so below the costal cartilage, and at the level of the intertubercle. This is anterior superior iliac spine, anterior superior iliac spine. So sizes. So this 9 abdominal region, right hypochondriac region, epigastric region, left hypochondriac region, right lumbar region, left lumbar region, umbilical region, right iliac, left iliac, and hypogastric region. Okay, so where is our liver located at? Okay, all right. Okay, based on the 4 abdominal quadrants, the liver is located at the right upper quadrant and left upper quadrant. And based on the 9 abdominal regions, our liver can be found in the right hypochondrium, the epigastrium, and actually some of them may extend up until the left hypochondrium. Okay. Okay, this is the face anatomy of the liver. So this is the face marking of the liver. How can we mark the liver? Okay, beside the location of the abdomen, the surface marking of the liver is really important too. So you have to know how to describe the surface marking of the liver. Okay, based on this picture, okay, we can mark the liver based on this 5 point. Number one is the upper margin of the liver, the mid at the midline. It's at the same level of xiphisternal joint, the joint between the xiphisternum and sternum, so xiphisternal joint. And from this point, it arching upwards on each side. Arching. Okay. And to the left, and it is up until the fifth intercostal space. Okay, the left end of the liver is up until the fifth intercostal space, which is approximately about 7 to 8 centimeters from the midline. Okay, and then to the right end, it's up until the fifth rib before it curves down to reach the seven ribs, and through this and end from the 7th rib until the 11th ribs is at the mid-axillary line. So it's at mid-axillary lines. And then its lower margin, the lower margin of the liver is from the approximately is the 10th rib at the mid-axillary line to the left end of the liver. Okay, where is the left end of the liver? Is at the 5th intercostal space. Okay, from the xiphisternal joint, it's arching towards the left end at the 5th intercostal space, and toward the right end at the 5th rib before it curves downward to reach the 7 ribs. From the 7 through the 10 or 11 rib, they curve down at the level of the mid axillary line, and the lower margin is from the 10 ribs until the left end of the liver. Okay, describe the lobes, the surfaces, relation. So we go into the lobes of the liver. How we describe the lobe of the liver based on anatomical and functional lobe. So the anatomical lobes of the liver can be divided into right and the left lobe. Okay, right and the left lobe. In anatomical lobe, the right and the left lobes are divided by ligament. Okay, number one is the falciform ligament. Falciform ligament. Yeah, the falciform ligament is actually continuous with the ligamentum teres. Ligamentum teres. And from posterior surface, it is divided by the ligamentum venosum. Ligamentum venosum. So there are two ligaments: interior falciform ligament, posterior ligamentum venosum. And falciform ligament is actually connected to the ligamentum teres. Okay. Because of this division, the right lobe is larger than the left, and anatomically, the caudate. This is the caudate lobe, and this is the quadrate lobe. Because of this division, anatomical division, the caudate and the quadrate lobes are included in the right lobe of the liver. Okay, now we go to the functional division. Functional division of the lobe of the liver based on its function. Okay, this functional lobe is divided into based on according to the duct system and blood supply, and they are equally divided into the right and the left lobe. Equally. The division can be done by drawing a line, an imaginary line, oblique plane through the midline of the gallbladder. So the gallbladder, the midline of the gallbladder, and the inferior vena cava. So this is the division of the functional lobe of the liver. So this is the right lobe of the liver based on functional lobes, and this is the left lobe of the liver based on the So it's divided by this oblique plane, passes through the gallbladder and the inferior vena cava. So what happened? What happened when we divide this at this point? So the right lobes, so the remember our quadrate lobe and the caudate lobe, they fall into the left lobe of the liver. Okay, so there's a right and left lobe based on the functional division, and the caudate and quadrate is included in the left lobe of the liver. Segments of the liver. There are surgical segment of the liver. The segments is based on the blood supply and biliary drainage. And so, according to functional lobe, each of the functional lobe will be divided into 4 segments of the liver, surgical segment of the liver. For the left lobe, now we go to the left lobes. Okay, we have this left medial superior, and then we have left medial inferior, which is the caudate lobe, and then the left lateral inferior and the left lateral superior. So this is the division of the surgical segments of the left lobe. Okay, now we go to the right lobe. Okay, for the right lobe, it's also 4. Okay, it has right posterior superior, right posterior inferior, right anterior inferior, and right anterior superior. Surfaces of the liver. Okay, for the liver itself, there are 2 surfaces: diaphragmatic surface, anterior, superior, and posterior right surfaces. They are all smooth. Okay, and the visual surface. The visual surface is this one. They're concave and is molded to adjacent visual with many landmarks. Okay, a sharp inferior border of this one. Okay, of the visual surface is actually separating the visual and the diaphragmatic surface of the liver. Okay, relations. The relation of the liver can be described based on the impression that are present in the liver. So, if this, okay, this is the left lobe. So this is impression for the stomach and the pyloric part of the stomach. So the left lobe is related to the stomach, the pyloric part of the stomach. And this area is the impression for the esophagus. Okay, yeah. And then this is the duodenum, and the right kidney with the adrenal gland on top, and then hepatic flexure of the large intestine. So hepatic flexure is also the right colic. Okay, and this is the IVC, inferior vena cava, which is related to the right abdominal lobe of the liver, and this is the gallbladder. As for diaphragmatic surface, it's obviously they are related to the diaphragm. Okay, one of the most important part in the gross anatomy of the liver are the ligaments of the liver. Liver ligaments are double-layered folds of peritoneum that attach the liver to surrounding organs or to the abdominal wall. Some of the ligaments associated with liver are remnant of embryological blood vessel and replaced as the fetus develops. Okay, these are all the ligament. Right, actually, remember I told about the barrier, which is bounded by the coronary ligament. Okay, the right coronary ligament and the left coronary ligament, and the right and the left coronary ligament is continuously to the left, as the right triangular ligament, and to the left as the left triangular ligament. Okay, let's go one by one. Okay, the coronary ligament. So this is the coronary ligament. Okay, coronary ligament. It is a peritoneal reflection from the diaphragmatic surface of the liver onto the diaphragm and encloses the barrier of the liver. And the left and the right triangular ligament, extension of the coronary ligament. Okay, fasciculum ligament connects the liver to the diaphragm and anterior abdominal lines. Okay, ligamentum teres of liver is also known as round ligament. It is an obliterated cleft umbilical vein, lies in the free margin of the falciform ligament, ascend from the umbilicus to the inferior surface of the liver. It used to be the most important structure in fetus, okay, because it carries blood from the placenta to the fetus through this structure called the umbilical vein. So when the baby born, this structure will become obliterated. Okay, the remnant of this structure is known as the ligamentum teres. It's connected to the umbilicus inferiorly. Okay, from the visual surface, there is one ligament, which is the ligamentum venosum. It is the fibrous remnant of the ductus venosus, which is the most important structure in the fetus circulation too. Okay, this is the ligamentum venosum. And beside that, there are also hepatoduodenal ligament. Hepatoduodenal ligament. Okay, hepatoduodenal ligament is this one. Connect the liver and the duodenum at the edge of this hepatogastric ligament. So this one whole thing is known as hepatogastric ligament. Okay, this is the hepatogastric ligament, and plus the hepatoduodenal ligament are known as lesser omentum. Lesser omentum. Hepatogastric is connecting the liver and the lesser curvature of the stomach, okay, while the hepatoduodenal is connecting the liver to the duodenum. Okay. Okay, this is all about the ligament. Now we go to the porta hepatis. Porta hepatis is the hilum of the liver. So this is the hilum of the liver, the portal vein, portal vein, the bile duct, the hepatic artery, nerves, and nerve enter the liver. So this is the porta hepatis of the liver. Okay, blood that enter the liver can be divided into two sources. Okay, one is the portal vein, which is a majority or most of the blood that enter the liver is from the portal vein, approximately about 70%. There are venous blood from GIT. Okay, venous blood from GIT is rich in nutrients that have been absorbed from the GI system, so they need to be metabolized or processed in the liver. So 70% of blood enter the liver is from the portal vein. Second one is the hepatic artery, which just bring in about 30% of the blood that is highly oxygenated blood that bring the oxygen to the hepatocyte. Okay, and the blood drain out from the liver from 3 hepatic veins. Okay. 1, 2, 3 hepatic vein and into the inferior vein. What is the portal vein? Okay, what is portal vein formation or portal circulation? Portal vein drain from blood from GIT, GI tract, the spleen, the pancreas, and gallbladder. Portal vein is formed by the union of splenic nerve, splenic vein, superior mesenteric vein, and also inferior mesenteric vein, which join the splenic vein. It's portal vein. It contains highly nutritious blood from the GI system. Portal caval anastomosis is a type of anastomosis which occurs between the veins of the portal circulation and veins of the systemic circulation. So they are anastomosing between the portal circulation directly to the veins of the systemic circulation. We have so many places in the GIT that has this portal caval anastomosis. Okay, in case of portal hypertension, if the patient has some diseases involving the liver, they might have portal hypertension. Okay, this what happened in this portal hypertension, the anastomosis, this anastomosis may become engorged, dilated, varicose, and subsequently ruptured. Okay, these are all the portal systemic anastomosis. Number one is at the lower esophagus. Okay, the anastomosis is between the esophageal branches of the left gastric vein. Okay, to the esophagus. Number two is the upper anal canal. Okay, between the superior rectal vein and the middle or inferior rectal vein. Then you have the umbilical, between the vein of the ligamentum teres and the superior or inferior epigastric veins. And at the back area, there is the hepatic or portal vein and inferior phrenic veins. And this is quite rare, the patent ductus venosus. If it is patent, okay, it's supposed to be obliterated, but in some cases it's patent. So that the anastomosis is between the left branch of portal vein and the inferior vena cava. And number 6 is the retroperitoneal, which is between the coronary veins and the body wall vein. All right. Okay, what happened if in portal hypertension, varicose may happen. Varicose is the enlargement or dilatation of this vein, and it may rupture. Okay, it's dilate and it's tortuous. Okay, that's the meaning of the varicose. Okay, this among the three most common site for varicose. One is the esophageal varices. Yeah, it's at the portal caval anastomosis between esophagus and the left gastric vein. This is because esophageal varices. What happens if it is ruptured? The patient might have hematemesis or vomiting blood. Okay. Number 2 is hemorrhoids. Okay, hemorrhoids is pile, or in Malay it is called buaser. Okay, this is when there is portal hypertension involving this anastomosis, which is the superior rectal vein and the middle or inferior rectal vein. The veins in the anus will become dilated, tortuous, and may eventually ruptured that cause hemorrhoid bleeding. And paraumbilical veins and epigastric vein, and this will cause caput medusa, is where you can see actually the dilatation of the vein. When this condition usually happen in a man, a person with abdominal distension, you can see the vein like surrounding the umbilicus is dilate, enlarged, and tortuous. That is called the caput medusa. This is the caput medusa. So in this case, it's not really the distended abdomen. Caput medusa is the appearance of distended and engorged superficial epigastric veins, which are seen radiating from the umbilicus across the abdomen. So this patient might have the portal hypertension. Okay, now we go to the microscopic structure of the liver as the basis of portal lobule and lobes. Okay, this is the liver. One liver has so many lobules. Okay, 1, 2, 3, 4, 5 more than it's uncountable. Okay, liver lobules, and each lobule looks like this. Okay, each lobule is surrounded by branches of hepatic artery, okay, portal veins. They provide nutrients and bile duct. This vessel drain into capillary-like structure called sinusoid. This is the sinusoid. So this is the sinusoid. They exchange materials directly with hepatocytes surrounding the sinusoid, and the sinusoid drain into the central vein. So this is the central vein, which drain deoxygenated blood into the hepatic vein. Hepatocytes also produce bile at the same time. They produce bile, and they drain the bile into the canaliculi of bile duct, okay, and drain into the bile duct, and eventually we restore the gallbladder. Okay. This is some applied anatomy of the liver. As I mentioned, there are 4 segments, surgical segment of the liver of each lobe based on the functional division of the lobe of the liver. So because of that, liver lobectomy and segmentectomy is in the case of where someone with disease liver, for instance, in segment 7 in this picture, the surgeon can remove this whole segment without damaging other segment of the liver, because each segment of this segment is supplied and drain the blood individually. Okay, this is liver lobectomy and segmentectomy. And number 2, cirrhosis of the liver is due to progressive destruction of liver cell with replacement by fibrous tissue. So the liver become hardened, and it's not be able to function well. The liver is easily ruptured because it is larger, fixed in position in fiber. The bleeding may be severe if it is ruptured. Okay, now we go to the second part, which is the biliary tree and gallbladder. So biliary tree is a series of gastrointestinal ducts allowing newly synthesized bile from the liver to be concentrated and stored in the gallbladder. Okay. This biliary tree consists of the right and left hepatic ducts. Okay, right and left hepatic ducts, which unites at protohepatis. Okay, we have protohepatis to form the common hepatic duct. The common hepatic duct joins by the cystic duct to form the common bile duct. Okay. The common bile duct unites with the pancreatic duct, the main pancreatic duct, to form the ampulla of Vater and open into the second part of the duodenum at the major duodenal papillae. Ampulla is surrounded by sphincter of Oddi. Okay, remember I inform you about the relation of the biliary tract and the foramen of Winslow. Foramen of Winslow, or people like foramen. Okay, this is the foramen of Winslow, or people like foramen. It is a passage between the greater sac, peritoneal cavity proper, and the lesser sac. So we learn this more in the abdomen, peritoneum and cavity. Okay, the peritoneal cavity proper and the lesser sacs, allowing communication between these two spaces. Okay, this is the lesser sac, and this is the greater sacs. The foramen of Winslow is connecting these two sacs. Okay, this foramen located at the posterior to the hepatoduodenal ligament. Remember I teach about the hepatoduodenal ligament. The hepatoduodenal ligament is the edge of the hepatogastric ligament of the lesser omentum. Okay, the hepatoduodenal ligament, which contains the bile duct, the portal vein, and the hepatic artery. So the foramen of Winslow is actually located posterior to this hepatoduodenal ligament, and the foramen of Winslow is the opening connecting the lesser sac and the greater sac. Okay, second one is the gallbladder. Gallbladder lies in the gallbladder fossa on the visual surface of the liver. It may contain about 30 to 50 ml of bile, and it's covered by peritoneum except when it is in direct contact with the liver. Okay. They are covered by peritoneum except at this point where they are in direct contact with the liver at the gallbladder pad. Okay, these are the parts of the gallbladder. Okay, the fundus, the body, the neck, and the cystic duct. The fundus extends below the inferior margin of the liver, behind the tip of the 9 intercostal cartilage. And the body continuation up is the continuation upward of the fundus. It passes backward, upward towards the right end of the portal hepatis, in contact with the first part of the duodenum, and its upper part narrows from the neck. The next continuous with this cystic duct. At the wall of the neck, there is a small dilatation which is known as Hartmann pouch. Okay, the fundus, the liver, the body, the neck, the neck. Okay, the infundibulum or Hartmann pouch, and this is the cystic duct. Gallbladder is supplied by cystic artery. Okay, cystic artery is a branch of the right hepatic artery. Kellogg's triangle is a triangular area formed between the visual surface of the liver above and the common hepatic duct. On the right, and the cystic artery lies between the triangle, between the visual surface of the liver, the common hepatic duct, and cystic duct. So this is the Kellogg triangle. So the cystic artery lies within this triangle. So when surgery involving this area, the surgeon might have to identify this triangle so that they can identify the cystic artery, and if they need to divide, they will divide, and like that, to prevent bleeding during the surgical procedure. Okay, the cholecystitis is inflammation of the gallbladder. It can be due to infection, or which secondary to the gallstone infection, which is known as cholelithiasis. It's defined as gallstones collects in gallbladder and may block the bile duct. Block the bile duct, and because of this, then they will the person that experience this blocking might have biliary colic, which is very painful, and they may appear yellow due to obstructive jaundice. Okay, this is the gallstone, which can be visible through X-ray. I think that's all. I wish you all the best, and thank you for your attention.